All right, so welcome everyone. We have our final session of our QI/QM Booster Blitz session today for our series. And today we're going to be talking about medication safety assessment, anticoagulants, antipsychotics, and diabetes medications. We have Teresa Lebowski here, our subject matter expert, who's going to be leading us through the discussion. If you have any questions, be sure to put them in chat. We'll be sure to get through the content and answer anything that you might have. So as a reminder, we are the IPRO QIN-QIO. IPRO holds the federally funded Medicare QIO contract for 12 regions as shown here. IPRO themselves cover New York, New Jersey, and Ohio, while Massachusetts covers, while Health Centric Advisors covers Massachusetts, Connecticut, Maine, New Hampshire, Rhode Island, and Vermont. And Clarent covers Maryland, Delaware, and the District of Columbia. So together we are 3 companies under the IPRO QIN-QIO umbrella. So we want to start off with our Booster and Beyond series as usual with the COVID-19 vaccine booster update. So I want to pass this over to Mary Ellen to give us some information.
Thanks, Josh. So just a brief update, looking at the numbers for the bivalent booster, and we're doing well out of the gate. 4.4 million doses have been received. People have received the updated booster, 4.4 million as of 9/28. That's a nice number, but as we know, that doesn't always translate to percentages. So historically, booster rates have been under 50%. So it's just something to keep in mind, hopefully, as vaccine campaigns are ongoing, that we'll get the message across to people how important it is. I did check on the CDC website on the When Are You Up to Date app. If people recall, that was a interactive tool you could use to see where you were at with your vaccines. So I put myself in, and it does ask if you've gotten the updated, or it asks you a series of questions. And then it does bring up the updated bivalent booster that you're due for it. So they have updated that app, and it's very helpful for people if they're not sure if they qualify for the booster. So I encourage people to look at that and spread the word. And finally, just to let folks know who don't already know, that we have started our Vax Chat series, which started 2 weeks ago. And this Thursday, we're going to be talking about the bivalent booster. So if you haven't registered for the series, the link is here, and we'll put it in the chat as well. It's 15 minutes rapid fire discussion on vaccines. It was our maiden voyage was well attended, so we're hoping to see those numbers rise. And that's it.
Perfect. And here's some additional
documents. So forget about that one. Yeah. So as always, there's some link to documents for folks. These are updated on a regular basis. So just want to keep them in the back of people's minds to take a peek.
Perfect. Thanks so much, Mary Ellen. And with that, I'll pass it over to Teresa.
Thanks, Josh. So as Joshua mentioned, today we're going to be talking about medication safety assessment and 3 of the high-risk medication classes: anticoagulants, diabetes medications, and antipsychotics. So our goal for today is to review Medicare beneficiaries' rates of adverse drug events due to these high-risk medications, provide an overview of the IPRO medication safety assessment results, and the ability to compare your facility to aggregate nursing home data, share how to manage high-risk medications such as anticoagulants, antipsychotics, and diabetes, and provide information on important resources for your facility. And last, and probably most important, invite you to participate in our high-risk medication safety learning circles. Next slide, please, Josh. So this article on adverse drug events in older people was published in JAMA in 2021. And the goal was to describe the characteristics of ED visits for acute harms in the US. And the article finalized that there were 6.1 emergency department visits for harms per 1,000 population, and that includes all ages. And of these, 39% resulted in hospitalization. So it is a significant issue. these adverse events. Rates were higher for people greater than 65 years of age. And by age group, the most frequent medication types with ED visits were anticoagulants and diabetes agents for patients greater than 65. Next slide, please. So what I'd like to do now is review IPRO's medication safety assessment. Next slide. So to give you the background on this, the medication safety assessment, the purpose of this was to identify high-risk medication management gaps and best practices to apply quality improvement solutions. So the time frame for our assessment was June to September 2022, and the assessment remains available until November 2024 for any care setting that would like to assess themselves. The focus is on management of these high-risk medication classes, as well as med reconciliation and antibiotic stewardship. The care settings that we've reached out to include hospitals, long-term care facilities, primary care, and home health care. The geography are all the states that Josh showed you earlier on that slide, the 11 states and the District of Columbia. To date, we've received 190 responses to the assessment. 130 of those were long-term care facilities, 48 were hospitals, home health care were 10 responses, and primary care 2. Next slide, please. So one of our goals with this medication safety assessment is to create a publicly viewable dashboard so that when you take the assessment yourself, you could go to the dashboard then and see what others answer to the questions that you are assessing for your own facility. And it'll kind of give you a nice way to see kind of where you are in the scheme of things. So this is an example of how our public dashboard will look with aggregate data. And again, it'll allow you to compare your own responses to the aggregate to hopefully identify opportunities for improvement or new activities to focus your efforts on. So this example shows the anticoagulation results, and we'll look at the results in more detail coming up next. Next slide, please. So here are some of the results from the anticoagulation long-term care responses. And this is a summary of all 130 assessments that have been completed to date. So if we look on this slide here, you can see I put down the percentage of nursing homes or long-term care facilities that answered yes. So with a structured discharge process for all anticoagulated patients, 32% of people said yes. Standardized patient education process specific to anticoagulation, 42% said yes. Standardized family education, 27% said yes. A formal process for patient monitoring, proactive patient assessment for bleeding, standard processes for reporting bleeding events, and medication adherence. Here it was a little higher, 51% said yes. Formal process for responding to anticoagulant-related bleeding events, for example, reversal policy, vitamin K protocol, 65% said yes. Structured peri-procedural management process. So before and after planned surgery or invasive procedures, do you have a process to manage people on anticoagulants? 34% said yes. And do you have a process to promote increased prescribing of the direct oral anticoagulants and reduce warfarin prescribing? And here is a very small number, 19%. So if we look at these anticoagulants, the highest one was the formal process for responding to anticoagulation related bleeding events. So the goal here is for you to provide you an assessment to review your own practices and then compare to others. So if you're looking through here and you don't have a formal process for patient monitoring, whereas 68% of the people that responded did, that might be a nice starting point for you to start to look into and plan for the future. Next slide, please. This next one is our results from the diabetes medication assessment from long-term care facilities. So here, required clinician training specific to diabetes, 28%. Structured discharge process for all patients with diabetes, Only 33% said yes to that. Standardized patient and family education specific to diabetes, 48% said yes. Formal process for monitoring proactive patient assessment for hypoglycemia, 68% response positive. And a formal process for responding to diabetes medication-related hypoglycemic events, 66%. So those last two are definitely, well, greater than 50%. So look excellent. And the others, there's opportunity probably for some improvement. Next slide, please. And this one is the antipsychotic medication results. So people who utilized antipsychotics only for approved indications, 46%. Dose reduction program when not clinically contraindicated, yes, 65%. Review of antipsychotic use upon transitions of care, 68%. So two of them are excellent. And the goal for this assessment is to review best practices and, most importantly, identify the gaps. So all of these are considered best practices, and it's a nice way for you to identify gaps. Next slide, please. So now that we've looked at the medication safety assessment results and opportunities to improve care, what I'd like to do is share some IPRO resources and ideas for utilization of them for some of these high-risk medication classes. And we'll start with the antipsychotic medication. Next slide, please. So IPRO has developed an antipsychotic template action plan with SMART goals. And the template action plan includes sample root cause analysis statement, SMART goals, and PDSA cycles. And in this action plan, any single SMART goal can serve as an individual performance improvement plan. The action plan template also includes resources to assist you with the interventions and the SMART goals. So if we look up at the top here, I put the 4 SMART goals that are included in the action plan, and we'll just review one of them together here today. So number 3, increase the number of antipsychotic gradual dose reduction attempts initiated by, and you put your certain percent, and that would be after discussion with your clinical team, your medical director. And within the next 90 to 120 days, including documentation of indication, outcomes, and failed attempts in the medical record. Consider a goal of gradual dose reduction for a minimum of 5 residents per month. And again, the important part here is to confer with your medical director, your prescribers, your clinical team, your consultant pharmacist to set that goal. All of the SMART goals included in the action plan are SMART, meaning that they are specific, measurable, achievable, realistic, and time-bound. Next slide, please. This is another part of the action plan. The action plan is 4 pages long. So this is the part that outlines the PDSA cycles in a template to allow you to get, to give you a starting point, a place to begin. So in the PDSA cycle section, the key action steps are outlined, the process owners, most often multidisciplinary teams, the monitoring strategy, findings and lessons learned, and then the next steps. So the action plan template really represents a comprehensive assessment that can be completed 1 goal at a time, or 2 at a time, or all 4 at a time, depending on your resources and what you have, to do this work. This action plan is created in Word, so modifications can be met to meet your individual facility needs. Next slide, please. This is one of our education resources for nursing home staff. And it lists it's designed to educate nursing home staff with the goal of identifying adverse events early. So it has information about ADEs, including the definition, the facts, common ADEs, and occurrences that could point to an ADE. So the ones that could point to an ADE are located in the yellow box on the upper right-hand corner there. And examples in there include transfer to a hospital, call to a physician regarding new onset of relevant signs or symptoms, addition or removal of a medication. it is estimated that about 50% of ADEs are preventable. So some common ADEs of antipsychotics are listed with the pictures, the pictures to accompany them. And examples include sedation, falls, confusion, orthostatic hypotension, loss of facial expressions, Parkinsonism, destabilized blood sugars, anticholinergic effects like dry mouth, constipation, urinary retention, cardiac arrhythmias, tardive dyskinesia, or a neurological disorder characterized by involuntary, uncontrollable movements. So you see there are references too at the bottom of the resource. And I think this resource, this nice one-page flyer, is great for distribution during staff meetings or educational events, just to remind people about the adverse events that are associated with this class of drugs. Next slide, please. Next up are the anticoagulation resources and how they can be used in interventions to meet best practices. Next slide. So the Anticoagulation Forum, in partnership with the FDA, recently released the identified 7 core elements for improving management of anticoagulants. They call it the playbook, and it was developed with input from more than 30 experts. It offers detailed strategies for each core element and is designed to be used by organizations who are establishing or considering anticoagulation stewardship program, as well as those with existing programs in place. The core elements do apply to the long-term care setting as well, to identify best practices for anticoagulation management, and maybe a place for you to partner with your local hospital. Next slide, please. So this slide, this is the summary of the core elements for anticoagulation stewardship. And we will review resources that can be utilized to address the 3 red core elements outlined here on this slide. And as I mentioned earlier, I think you may want to collaborate with your hospital partners to advance some of these core elements. So the core elements include securing administrative leadership, establishing professional accountabilities with a single leader, engaging multidisciplinary support, performing data collection, tracking, and analysis, implementing systematic care, facilitate transitions of care, and advance education, comprehension, and competence. Next slide, please. So the first anticoagulation resource I'd like to share with you is the Anticoagulation Discharge Communication Core Elements. And this addresses the core element of facilitating transitions of care. This document was designed for use by facility or a healthcare provider to improve cross-setting management with the goal of preventing adverse drug events and subsequent emergency department visits, hospitalizations, and readmissions. You should think of these discharge communication elements as something that can be applied to residents that are admitted from a hospital, where you check and make sure all those things are present when you accept that resident, and also for your short stay residents when you send them out to the next level provider. Some examples of discharge communication elements include: is there an indication for therapy? A documentation indicating if the treatment is intended to be acute or chronic, the timing of your last dose, if on warfarin, what was the last INR and the target INR, and the most recent assessment of renal function, and more. So that's like a multi-page document. Let me look at it now. 1, 2, 3. I think it's like 3 pages long. And we can provide the link to these with our follow-up communication. Next slide, please. The second anticoagulation resource that I'd like to address is our managing anticoagulation during the peri-procedural period. This resource addresses the core element of implementing systematic care. So when residents have surgery or any invasive medical interventions and they're on an anticoagulant, you have an increased risk of bleeding. But at the same time, while you're withholding the anticoagulants, you increase the risk of thrombosis. So the clinical team has to balance these 2 competing risks and make educated decisions regarding when to interrupt your oral anticoagulant If it's interrupted, do you need to bridge? And when to restart. And that's really the goal of the MAP app, is to assist clinicians in those decisions. It guides decisions regarding interruption and when to use bridging. It provides detailed guidance for drug dosing and laboratory monitoring, and encourages clear communication. And I've been told any individual resident could be assessed in like 4 clicks in this app. So it's easy to do, quick, and it gives you all of that information. So this app can be used by your clinical staff for discussions with medical director, with consultant pharmacist, to bring everybody on the same page, and again, stressing that systematic care process. And up at the bottom of the slide, you can see the link to get that MAP app free of charge. Right there, mappp.ipro.org, so 3 Ps. Managing anticoagulation during the peri-procedural period. Next slide, please. This is the 3rd resource for anticoagulation. Again, a flyer for staff education. It looks similar to the other, but now it's outlining for anticoagulation. And you can see the common anticoagulation adverse events with the pictures. And these include abrupt onset of hypotension, low platelet count, an elevated PT or PTT, INR, bruising, nosebleeds, bleeding from gums, prolonged bleeding from wound, IV or surgical sites, blood in urine, feces, or vomit, pain or tenderness and swelling in an upper or lower extremity, feelings of anxiety or dread, and unexplained shortness of breath or chest pain. And up at the right upper corner again, in that yellow box, are occurrences that could point to an anticoagulant ADE, such as a stat order for a PT, INR or PTT, platelet count or CBC, a stop order for a medication, the administration of vitamin K, a reversal agent for warfarin, a stat chest x-ray, a stat scan for DVT, or transfer to a hospital. So the references are again at the bottom. Next slide, please. So now we'll move on to the next high-risk medication group, which is diabetes medications. So these, and I put right under here some recommendations for interventions that are common with this group, and that is decrease the use of sliding scale, increase the use of insulin pens, and decrease the use of sulfonylurea medications. Diabetes is more common in older adults and has a high prevalence in long-term care and is associated with a significant disease burden. And there definitely is a need for person-specific goals and treatments for diabetes. The risk of hypoglycemia is an important factor in determining glycemic goals. And simplified regimens are needed, and the use of a sliding scale insulin should be avoided. Next slide, please. This slide includes a table from an article published in the journal Diabetes Care entitled Management of Diabetes in Long-Term Care. This article may assist in person-specific goals and treatments. This table in the slide is from the article, and it summarizes the advantages and disadvantages for each diabetes medication class, along with long-term care tips. So an example would be the GLP-1 agonists. So these are semaglutide, liraglutide, exenatide. That's like Byetta, Ozempic, and Victoza. The tip for long-term care is to monitor for weight loss and anorexia. So there's similar tips for all of the classes of anti-diabetes medications. In addition, this article also provides recommendations on how to replace sliding scale insulin in long-term care facilities. This would serve as a great education resource or presentation to clinical staff in collaboration with your consultant pharmacist and your medical director. Next slide, please. So here, these are 2 additional diabetes medication management resources. The first is your ADE flyer again. So now this is the 3rd in the set. And some common ADEs of diabetes medications are listed again with the pictures. Unconsciousness, falls, lightheadedness, dizziness, sweating, hypo or hyperglycemia, headache, nausea, excessive thirst or urination, tingling or numbness in the lips and or tongue, rapid heart rate, change in mental status, emotional changes, shakiness, nervousness, irritability, and seizures. So presenting symptoms of hypoglycemia in older adults can be primarily neural-related, like confusion, delirium, and dizziness, that circle, rather than the palpitations and sweating that we're all probably more accustomed to with younger patients. The second resource on the page is the Diabetes Discharge Communication Elements. So this one, like the others, is set up to give you some items that should be communicated upon transitions of care. And examples of elements for diabetes medication include a recent blood glucose value, a history of hypoglycemic events, current anti-hyperglycemic drug regimen, and recent changes to that regimen. Next slide, please. So I would like to invite you to join us. We are starting an IPRO high-risk medication safety learning circle events. Our first one is on November 2nd, 2022, and it will be recurring every first Wednesday from 2 to 3 Eastern Standard Time. You can email Ann Merka at ipro.org to receive the calendar invite. No pre-registration is required. And during our first meeting, we want to have an open discussion on what you need to manage your high-risk medications. We can talk about audit tools, we can review data, assist with tools, resources, and education. And our goal is rapid improvement with short plan-do study cycles of improvement. Next slide, please. This slide provides you the links for our medication safety assessment. It's not too late to take it, so you still can. And also the link for our opioid and pain management best practice assessments. And IPRO will provide aggregate data dashboards to allow you to compare your answers for both of these assessments. Next slide, please. I think that is my ending slide. So I'll leave it with questions, and then I put my contact information there, as well as Ann Merka's again to join our learning circles. Back to you, Josh.
Sure. So does anyone have any questions? You can make sure to put them in chat, or you can come off mute. We invite you guys to chime in some questions or comments.
And if you don't want to say the questions out loud, yes, you can just leave them in chat and we can answer them, right, Josh?
Yeah, absolutely. We can definitely follow up. So while people are tuning in to put in any questions, I wanted to just also ask if this session was helpful to you, and if you would go back and do anything differently in your facility. Do you plan on doing any of the assessments or utilizing any of the tools that were shown today? We'd love to get some feedback from people on the call about this as well. And lastly, we do have a request for everyone on the line. Specifically, CMS has tasked us to ensure that we're supporting their nursing homes with COVID-19 and emergency preparedness. So we put together a short survey monkey that you can fill out and provide us the answers to. We're planning on collecting all of the responses from all the homes and utilizing that information that you provide us so that we can follow up with tools and resources based on your responses. So if you have an opportunity to please go to this link, would really appreciate you guys taking the time to fill that out. And as always, you can always go to our website. It's qi.ipro.org, where you can find events, our blog, look at the calendar for upcoming sessions, and can follow us on various social media platforms. And then you can contact anyone as well from the nursing home team. Our contact information is shown here as well. And Teresa wanted to share that there was a comment. I
Mhm.
work home health with people with mental health disabilities. This is great info regarding diabetic information and high-risk medications. I'll use this info with the community nurses for educational purposes. Thank
Great.
you.
Oh, that's great. That's a great, great utilization. I hope you like using those little one-page flyers. They're kind of quick hits. And if you have additional suggestions after you use them, please communicate it back to us. We would love to hear what you think of them when you're using them.
And I am putting that survey request link in the chat. If you guys could just please fill that link out on your way out. I don't see that there's anything else in well, actually, we do have one question that just came up. I have a question about a different topic than this webinar. I am in need of a monthly infection control tracking grid, one that tabulates per unit the number of respiratory infections, ENT, GI, systemic, UTIs, and skin.
I will put a link into chat in 1 minute. I just have to find it. It is our antibiotic and infection tracking tool. And I think that would provide you most of what you're looking for. And if not, you can reach out to me.
Yep. So thank you, Geraldine, for putting that in. Nancy Alphonse had shared, will the tools be available on the website? So Terry, are the tools provided in this webinar available on the resource library at the moment?
Yes, Josh. All of
Okay.
these tools are on the IPRO resource library. So I'm assuming right when we send the slides, we can send that link to the resource library right along with it.
Yep, and I'm getting that right now for
That
people.
would be great. Yes, in our resource library, we have it broken down, by nursing home. There's one section for opiates, etc. So you can pretty much pick and select. All those resources are there in one of those areas on that resource library.
Perfect.
Thank
Now,
you.
Geraldine, Melanie had provided the link to the infection control and antibiotic tracking tool form. So be sure to check that out. And I also had put in the link into chat for the IPRO resource library. Kathleen,
Thanks, Josh.
no problem. Kathleen mentions, I'm looking at a barcode bracelet, barcode scanner system that works with PCC. Does anyone have a barcode medication scanner?
You may want to talk to PCC to see what companies they've worked with in the past that connects with it. That might be a good choice, unless some colleagues on the line are using a system. That would be helpful too.
Certainly is a great step forward, though, in preventing medication errors. So congratulations, excellent move.
Hi, Josephine. I saw that you put in a request for the monthly infection tracking grid as well. So I did re-put that link into chat for you to be able to see that. And Lisa, the slide is going to be available from today's call. What the slides, Terry, the slides are 508 compliant already, right?
Yes, they are.
So in my follow-up email to all the registrants, I will provide a copy of the slides to everyone who participated as well. Perfect. All right, well, we are past time. Thank you so much, everyone, for joining. If you know anyone who would benefit from today's session tomorrow, we have the live recording that's going to be taking place at 3:30 tomorrow afternoon. And then, of course, we have our IP3 session on Thursday morning at 11 o'clock. So invite you all to come to that session as well. Thank you so much, everyone, for joining. Have a good day.